Now, our case study for acute renal failure is about a 73-year-old man admitted to the hospital with clinical manifestations of gastroenteritis and possible renal failure. The patient's chief complaints are fever, nausea, with vomiting and diarrhea for 48 hours, weakness, dizziness, and bothersome metallic taste in the mouth. The patient is pale, sweaty. The patient's eyes appear sunken with dark circles around them. Obviously, the patient is dehydrated. So, based on the information provided, which two types of acute renal failure are most likely? Now, the most likely two types of acute renal failure in this patient are pre-renal or intrarenal. Pre-renal or intrarenal, because there is nothing that points to obstructive uropathy here. So, apparently, this renal failure was precipitated by dehydration secondary to diarrhea and vomiting. There is no information that would suggest obstructive uropathy. List the risk factors that are likely contributing to the patient's kidney failure. In this patient, we have these risk factors. The most important one is hypovolemia from dehydration caused by this diarrhea and vomiting. And also the patient has heart failure. Heart failure decreases the cardiac output, decreases the renal blood flow. And also this patient is using diuretics, furosemide, for his heart failure, which will further decrease the blood volume. And the patient started recently ACE inhibitor. ACE inhibitors, although they are kidney protective, but when you start them initially, you will get drop in your GFR, and this will contribute also to the acute renal failure in this patient. Which urine analysis information suggests that acute renal failure in this patient is not the result of glomerular disease? Now, the glomerulus is where you do your filtration. And filtration simply is a pressure-related process. So the higher the pressure, the more the filtration, and vice versa. When you have normal pressure, everything passes out of the glomerulus. The glomerulus is a capillary. Everything can pass out except proteins and blood cells. When you have a disease of the glomerulus, when you have a bad glomerulus, your glomerulus becomes leaky. So what do you expect to see in urine? Proteins and blood. So you get proteinuria and hematuria. So proteinuria and hematuria, these are the common signs of any glomerular affection. In this case, the patient, neither protein nor blood cells were observed in urine. Do the urinary microscopic analysis, specific gravity, sodium concentration, and osmolality suggest pre-renal acute renal failure or intrarenal acute renal failure? How? Due to acute tubular necrosis. How to tell the cause of renal failure in this patient? We have to do the sodium and water in urine, and we have to do also the BUN to creatinine ratio. So regarding the urine analysis, first of all, there was no CAS. No white blood cell cast, no crystals, no myoglobin, no hemoglobin, and this is consistent with pre-renal. Then the urine specific gravity is 119, kind of elevated. Sodium concentration is low, and the osmolarity is elevated. And this means what? Less sodium and less water in urine. This means your kidney can reabsorb. This means that the problem is not in the tubule. So collectively, this is going to suggest a diagnosis of pre-renal acute renal failure rather than intrarenal. Calculate the plasma BUN to creatinine ratio and see what does this ratio tell you. Is it consistent with pre-renal or consistent with acute tubular necrosis, which is intrarenal? Now the patient's BUN is 57 milligram per deciliter and the patient's creatinine is 2.6. When you calculate the ratio is going to be 21.9. What's 21? The normal ratio is 15 to 1. Here we have a ratio of 21. It's higher even than 20 to 1. And this favors the diagnosis of pre-renal over intrarenal acute renal failure. So this patient has pre-renal acute renal failure. Our case study about chronic renal failure or chronic kidney disease is simply about a 27, who is very young. Why does he have renal failure? We'll see. 27-year-old male was diagnosed 3 years ago with Good-Pasteur syndrome. Good-Pasteur syndrome. The patient then presented to the ER with a 6-hour history of coughing up blood. He also complained of difficulty breathing, chills, and chest pain. Lab tests revealed elevated white blood cell count and iron deficiency anemia. An ELISA test was positive for anti-glomerular basement membrane antibodies in the blood. And the patient was diagnosed with Good-Pasteur syndrome. What's Good-Pasteur syndrome? Well, the patient was told that it is an autoimmune disease of the kidneys and lungs, and that a potential serious complication of it is chronic renal failure. It's an autoimmune disease. So which type of immune hypersensitivity reaction causes this destructive renal changes in Good-Pasteur syndrome? Is it type 1, type 2, type 3, or type 4? Actually, it is type 3 hypersensitivity immune reaction, what we call immune complex hypersensitivity. So here we have antibodies are produced against antigens within the glomerulus basement membrane, and the immune complexes will form when antibodies bind with these antigens. And when we get these immune complexes, this will activate the complement, and some of the protein components of the complement system will attract inflammatory cells. And the result of this is glomerulonephritis, which can cause extensive injury to the structure of the glomerular filtration membranes. What is the pathophysiology behind the clinical signs of proteinuria and hematuria in this patient? Why we find proteins and blood in the patient's urine? Well, the glomerular filtration membrane loses the ability to selectively filter substances when filtration slits or pores are widened by inflammation. Inflammation will widen these capillary pores. So the proteins and blood cells are able to pass through these membranes into the urine. With time, the defects become larger, and proteins of higher molecular weight and more blood cells are also lost in urine. What is the likely cause of the abnormal lung sounds in this patient? The patient had abnormal lung sounds, and the most likely cause is mild pulmonary edema at the base of each lung. Why do we get the edema? Edema is an expected finding in a patient who is losing significant amounts of proteins in urine and has become hypoproteinemic. How come? Because intravascular osmotic pressure, or what we call the oncotic pressure, is gonna decrease with subnormal concentrations of plasma proteins. Now, I always say, what is the role of proteins in your blood? The presence of proteins, especially albumin in your blood, normal albumin in your blood, is like the presence of a professor inside a classroom. If students come to the classroom and the professor never showed up, what's going to happen? Students will leak outside the classroom. Students will leave the classroom. It is the professor who keeps the students, who retains the students inside the classroom. And so does albumin. It is albumin that keeps water inside the blood vessels. Without albumin, water is going to ooze outside, and this will lead to edema. So capillaries and other small blood vessels lose their ability to reabsorb and retain fluid within the capillaries, and this will lead to edema.